All right. Good morning, everybody. So my name is Joel Matthew Alfred, an occupational therapist working in Stepping Stone Center. So today's presentation, which I'll be presenting to you all, is about what is an occupation therapy and why is sensory integration is very, very important at early stages of a child's life. So, what is an occupation therapy all about? So, as the definition says, before starting with the definition, I would like to give a small insight on what exactly the term is. So, occupation, when you refer to the word occupation, so what exactly is occupation? It's just basic work that we do and ordinary and familiar things that people do every day in their life, right? So, for example, now today we have woken up, we have gotten from the sleep, and then till the time that we go back to sleep in the bed at night, we would do a lot of activities, a lot of various activities. Probably we dress, we bathe, we talk to people, we cook, we manage our household activities, we communicate. So there's a lot of things that we do. So either from a very simple task to a folding clothes to a bigger task where you manage household activities, everything is work. So what we do is very independent, right? So we try to do most of the things more independently as possible. Like we do take help, we do take an assistance from people or from family members or surrounding people, but still our work is complete, and because of such independency that has been exhibited from our side. So most of the work, since we are able to do it independently, our emotional and cognitive functions are much better. Like we would have a contentment that, okay, I have completed this work today and it's more complete and independent. So it gives a relief, no, it gives a functional aspect. It gives us an insight that we have done more functionally and productively. Let it be any kind of work. Now from the adult side, yes, we can relate to these household activities, and certain examples I've given. Basic aerial functions like dressing, bathing, and then for toileting, uh, folding clothes, these examples. Now when it comes to the context of children, now we will discuss more on basis of the children population, the pediatric and child psychiatric population. So I will give you an insight of what exactly the topic is talking to you about. Now from the child psychiatry, from the children's population, uh, what is their work? Their work is not being to do with any household activities. Of course they would like to help us around, but their actual work is play, right? So what activities, like any kind of games that you give, or any kind of tabletop activities, or any kind of physical task that they want to perform, the work that they are able to do or they wanted to do must be independent. For example, let's say I'm a child who wanted to start working from after getting up from my sleep. So after freshening it up, after finishing all my aerial tasks, my job is playing. So playing is more important factor right now, which I'm trying to do. Of course, I would like to color sometimes. I would like to scribble on the paper at times, or even I would like to play with the ball with my cousin. So it depends on various factors, like different activities. We cannot be very confined to only one particular activity what the child needs. There are a lot of activities what the child would like to do in a day. But is the question is like how much or how far the child is being independent, right? So if the child has to do a certain task or certain activity on its own, let's say a puzzle fixing activity, or a ball throwing activity, or a child has to just pick up a toy walking from one place to another, independency must be there. Only when the child is able to perform certain actions or his or her own task independently, we would say that the work is productive and the child would be emotionally enhanced. So concerning this topic, concerning this concept of what exactly is occupation. So what I wanted to tell you is that occupation is not exactly the work that we do. It's also depends on the productivity, and depends on the enhancement of functioning skill that actually what we do. If you want to take a simple example of folding clothes can be work, or arranging or cleaning the wardrobe can be a work, but how functional and productive we do is what it matters. Okay. So I'm an occupational therapist who will be presenting you about what exactly is occupation therapy all about. Now, since I had given you a concept of what exactly is occupation therapy, we would get in detail, a little bit in depth in the subject. I will not be explaining to you in more of a therapeutic language. We'll get down to very common language, and also I'll give you a lot of examples so that it'll be easy for you to understand. The more I explain, when you get into the depth of the subject, you will be able to analyze a lot of the things that is happening around with your child. uh, Probably there'll be one or the other two factors that you will be expecting. Yes, this can be happening, or this is what exactly that is happening with my kid. So please do not worry. It will be explained everything. I will be covering all the skills and the limitations that the child is facing in the day-to-day activities, and how occupation therapy is very important, and what kind of therapy, what kind of treatment that we majorly implement in a child psychiatric setups. Okay, yeah. So let's get started. Uh, so the introduction first. So as I told you, occupation is the word meaning that it's an ordinary and familiar things that people do in everyday living. Okay, so where the main categories of occupation will include work, self-care, play, and leisure. Now, OT is a very occupation therapy, or otherwise called as, is a very skilled treatment and helps people become successful in their day-to-day activities and occupations. And often, it is more achieved through the goal of independence, right? So whatever goal that we take across, whatever skills that we wanted to implement, everything will be based according to the independence factor, how far the child is able to be independent in completing this activity, or how far the child is being independent in performing this particular actions. Let it be any kind of actions or any kind of activities, that it depends on the child, or the depends on the task or the skill level of the child. But whatever functions that they do, they must be able to do it as independently as possible. Right. So now you might ask me a question. Why exactly a play has to relate with independence? Now, play, anybody can play. A child, when it's left with a lot of toys to be left, the child's decision to play whatever it wants to. Or it's not very necessarily that the child has to be independent like an adult to do it. But the reason why, in the context of independence that we are speaking, is because if the child is playing, let's say for example, playing with the vegetables or the toy animals, the 3D animal toys. uh, Now, in case if the kid or if the child is not able to functionally play, or uh, productively get that play in a play in the context, like for example, when I have to pick up a toy which is there right next to my left. Now, in order to reach, I need to get a little independent. Now, if I'm not able to reach to that particular toy, which is just next to me, I'll not, and I would expect someone else to do it. But what if that if the child is not able to communicate, or if the child is not able to call out for mama and papa? Definitely, they would start crying. They would start shouting. They will use some kind of other actions where or a gestures to prompt that they want something. Now, there is an assistance. So where is the independency there? Definitely there is an independency lack. Now, if I'm not able to pick up a small toy from one place to another, or if I'm not able to play more productively or communicate more productively, which hampers my social skill level also, then the play becomes entirely unproductive. And solitary play is something that we don't encourage much. Although there is solitary play, there must be productiveness and there must be an assistance involved, right? So since play is a basic platform for the child's learning process, we wanted the play to be productive. That's the simple concept. Now, what exactly is occupational therapy? So it is a branch of medical science that deals with the use of particular activities as an help in fostering or maintaining the development of the child to the maximum level of functioning possibility. Okay, so this is a very colloquial definitions. Just to give you an understanding of what exactly an occupation therapy is. So, as I told in the definition that is mentioned, it is the use of certain activities to develop the child's functioning to the maximum level of to the maximum possible level. Now, as I told you, right? So when we wanted to give a child any kind of task oriented activities, we would be giving as an activity based itself. Like if the child has to play with the ball, learn how to play with the ball, the treatment will be based only according along with how to play with the ball. Definitely, there are other prerequisite factors that we need to look into it. That which I will be discussing you down the lane. But using of objects is what the child will be taught about. And we don't focus more on just implementing it, but definitely more enhancing their functional level to the maximum possibilities, right? Okay, and then it is definitely the use of an assessment and intervention to develop meaningful activities or and work to the individual, where it helps them to participate the things that they want and need to do it. Now when we need to have a child participate in their particular action, or when we need the child to participate in the particular activity, we need to have an assessment and intervention that needs to be developed, right? So an assessment will help occupational therapist to and the parent to be more educated on what exactly is happening with the child. So there'll be a lot of factors that is underlying. Maybe if the child is not paying an eye contact to you, or not responding to your name call, or not listening to your instructions. So what is the exact factor that is there behind? So in order to be very precise on the intervention plan to implement, we will be very focused on the assessment part also as well, which is a very a crucial stage where we give a lot of importance, and also explain the parents about what is the importance of assessment and getting a detailed a report asking your datas and about the child and about yourself. So the assessment is divided basically into two types: subjective and objective. A subjective assessment is something to do with more of an observations, where we therapist and the child would be in a room where the therapist will be observing the child in their performance, in their task and their activities. And then the objective type is something that we will would ask questions. There are a few questions based on the format, the assessment format that's given. And then we will be comparing with the questions that you with the answers that you had given, and from the observation that we had taken, we would compare it and finally conclude that what exactly is the intervention that we need to foster for the children. Now, why do we need to do this? Why there are two kind of assessment, and what's the need for comparison? It's because children are not the same everywhere. Environmental influence is very big. Now, if the child does, probably the child is not listening to your instructions at home. But when they come to a particular environment or in a different place, maybe they listen to instructions more effectively comparatively to the home environment. So environment differs. But when I ask you, maybe you would say that yes, the child is not listening to my instructions. But when during the assessment, during the observation, I could see the child is able to listen to instructions, at least to 1 to 2 step commands. So where is the lag? To In order to understand where exactly is the problem, we'll be able to that is why this assessment is being done, right? The subjective and objective. This is why the comparisons. And it also includes the interventions that will help children with differently able to participate fully in school and social situations and provide support for the older adults. Definitely. So, the interventions will be all based on how the child can get independent in their functional activities. Okay. So now, what are the areas that we work in? Now, since I have explained a little detail on the child psychiatry setup or the children population itself, it is not to be misunderstood that we work or confine ourselves only to the pediatric or child psychiatry setups. There are different units or different areas that we work in, namely the adult neuro unit. So the adult neuro unit consists of only geriatric populations. Uh, Geriatric population, the patients who are affected with stroke, the patients who are affected with dementia, Parkinson's, and then head injuries, these kinds of patients. But very importantly, want to mention is the all units that we have mentioned here. It's all with the post treatment. So post treatment, in the sense, let me give you a small example. Now, a person has met with an accident, and he has been diagnosed with severe head injury. Okay, we call it in medical term as RTA, that is road traffic accident. Now, the first step would be where the patient would be directed to the medical emergency ward. The surgery will take place, and the doctor will give medications. He'll be under observation and in ICU. So the treatment and medications will go on. And once after this first step finishes, once the patient is out of danger, right? And then the doctor would suggest a few treatments. Maybe this patient would need physiotherapy, or the patient would need occupation therapy, or whether this patient would need more of a psychological interventions. So why the doctor suggest these kinds of treatment based on the patient's progress. Okay, now the patient will be again sent to, so that is a primary treatment what the doctors involved in, the surgery, the surgeons and the doctors involved in. And then the post treatment comes where we rehabilitation team members, healthcare professionals come in place. So it's not only occupation therapists but speech therapists, physiotherapists, dietitians, nurse and everybody else come under this rehabilitation unit. So it's like after the doctor's treatment, so it's enhancing their life in more in a better performance level. So for example, the patient has met with an accident, right? So he has a head injury, now he's out of danger, but there's also been diagnosed where his hand and legs are not being able to move. So his tone, the entire muscles are very very weak. Now, this is where now when it comes to an occupation therapy, so I'll explain only in context of occupation therapy. So when the patient has been suggested to occupation therapy, we would help the patient get more independent in the function activities in the day-to-day life. Now, if the patient is already having a muscle loss, muscle tone loss, okay, that is the right side weakness, we call it as hypotonia or hemiplegia. And now, when in the terms of hemiplegia, when there's a complete loss of muscle tone in a particular limb, the patient is not able to move that particular arm. Let's say the right hand itself. The right hand is not able to function. The patient is not able to move his right arm. So, how will the patient or how will that person will be able to pick up a certain object which is right next to him? Let's say there is a water bottle right next to him, and he has to, and he's feeling thirsty, and he wants to drink water, and when he or she is not able to pick up the water bottle right from next to him, that activity is incomplete. So definitely he has to call someone else for an assistance, or someone should be there assisting him like 24 into 7, looking after his needs. So those kinds of patients we would try to, there's a lot of different techniques and other procedures from the neuro unit where we would facilitate the muscle back into action, but again, as the definition says, to the maximum level of functioning possibility, right? Because of the age factors, we cannot expect to a complete 100% result. There will always be a little short delays, but definitely the work that is being done by the patient post surgery will be more independent and productive as much as possible. If not, at least to the previous time, how I'm able to productively reach out to an object, but at least using an and adaptive aid, or at least using some energy conservation technique, I would be able to pick up the object. But definitely there's no assistance, I would be done, I would have done that work more independently as possible. All right, so this is the picture that you get. So we work in post treatment methods. And then adult psychiatry unit where we give counselings, then pediatric unit, that is the children from the newborn till the age of 1 or 2, and child psychiatric unit, that is the children above the age of 2 or 3. So the current scenario that we are going to talk about is the child psychiatry unit, and the splinting and ortho unit. So splinting and ortho units is something called, we call it as splinting, right? So splinting and ortho units, splinting in sense, we have orthosis and prosthesis. Orthosis is something called a supporting device, and prosthesis is called as a replacement device. A supportive device, for an example, a cervical collar. So if your patient has or if an individual has a spinal shock or is a cervical shock or having an injury, or has fractured in a particular limb, and then in order to stabilize that particular joint, we would give these kinds of supportive devices. So one supportive device, for example cervical collar, which is used in this neck region, is an orthotic. And prosthesis is an artificial limb. If an individual in an accident has lost his limb or got amputated, so we would give a mechanical limb in order to function, as a replacement device. So we would work in manufacturing those devices. And on-core rehab unit is an cancer unit where we would provide counseling again. And then in industries mainly for the ergonomic and architectural barrier methods. So what do you mean by this ergonomic and architectural? In industries, we would counsel the workers and giving them an insight on how to exactly work without having any kind of back pain or any kind of physical strains. So in industries, you've seen workers work a lot. They stand a lot and they work, so that eventually what happens is literally the back pain occurs. So ergonomically, how you can conserve your energy and work efficiently is what that we try to counsel. Maybe they will work for a period of time, but later, after a certain age, this pain would be subjugated more, and definitely these workers will not be able to work independently, and again the independency is lost and assistance must be implemented. So in order to avoid the maximum assistance level, at least for the work where the workers must be done individually and independently, is what that we're trying to achieve. Okay, so these are the units and the areas that we work in. Now, explaining these areas that we work in, now you'll have a small confusion, like what exactly is occupation therapy is different from physiotherapy. Now, although when you look from outside, it looks very similar. So occupation therapy and physiotherapy does look similar when you look from outside, the way how we work into it. But still, there's a lot of factors and differences, minute differences that we need to look into it. It's vast. So there are three examples. Sorry, that there are three differences that I would like to give you. One is the restoring independency and mobility. So, who restores mobility and who restores independency? Physiotherapist will restore the mobility in a patient. Like as I told you, like that patient, like that person, after the ICU ward, he has been directed to physiotherapy and occupational therapy. Now, if that person comes to physiotherapy, the what the physiotherapist will do is they'll try to mobilize his joints and limbs, right? So let's take that example, the right limb itself. Now that limb is not being functional. The patient is not able to move that particular limb. So the physiotherapist, using the machines and modalities, they'll try to mobilize their limb. But occupation therapists would try to use this mobilized limb to get more independent in functional tasks. So hope you understood. Now I'm just moving your limb, and another person is helping you to reach out to a particular object with that limb. Okay, so reaching out to an object in a particular limb is an independency. I'll teach you how to move your limb and reach out to a particular object, but how that mobility comes is the physiotherapist tasks. And and also we focus more on functioning. Occupational therapists focus more on functioning, physiotherapists focus more on injury. That is, during the process of treatment, during when we are trying to train the individual, okay, in this restoring independency and mobility, they'll focus more on, physiotherapists will focus more on reducing the injury level. Like when I'm trying to mobilize a patient's limb, if I'm a physiotherapist, I will focus whether the patient should not experience any kind of injury. It can be a muscle injury or even a joint dislocation also. But occupation therapists here will focus on functioning. So although we focus on injury, but our main focus, high weightage will be focused on functioning. Like how functionable is the individual or the person is with that right limb, right hand, right? So the injury will be taken by a physiotherapist, like how well I'm functioning. If I have to take a particular object from the table also, it's not just like that I'm using any kind of other patterns and taking the object. Is it more functional? Is it more independent? Is the person having the correct stability and balance to hold and pick up the object? So that is functioning. And then definitely occupation therapy therapists will use a lot of daily activity tools. Like we don't use any kind of machines, we use the daily activities. Now if you want to teach the patient how to drink water from a glass, we'll use the water and glass itself. We will not use any other machines to use it. But physiotherapists will use a lot of machines to do it. So they are more mechanical, and we depend on more manual methods. But very importantly, occupation therapy and physiotherapy is very much needed to enhance a patient's independent living. Okay, so we fall under the rehabilitation team members, it's like to have a together input. Now without restoring the mobility, we will not be able to restore the independent level, and without physiotherapy focusing on injury, we will not be able to focus more on the functioning level. And even if the physiotherapy use machines, they are still focusing on the joint and the ligament mobilization, whereas occupation therapy, we have to use those terms in order to get our daily activities used efficiently. So physiotherapy and occupation therapy works together, and it's not entirely different. So yes, how exactly do we work? Now we'll come only to fix only to an occupation therapy. So we'll have a circle only centered only with occupation therapy. How do we exactly work? Now we have three rules: initial evaluation, interventions, and reassessment. Now, in initial evaluation, the assessment will be taken from the history of the child. So, I told you in the beginning of the presentation, right? So, we have two kinds of assessment. One is subjective and one is objective. So, this is where the initial evaluation comes, where we try to get the assessment done in both the aspects. One is through an observation with the child, and other is through asking few questions from the parents, and then compare with and then compare with what we got, the data what we got, and finally conclude to an intervention level. Now, this initial evaluation will not include only on the basis of one area, but in a different area, from the birth history to the motor evaluation, sensory evaluation, cognitive, social, and emotional functions. Now, you remember what I told you about the prerequisite skills that I'll be talking to you? These are the prerequisites. Now, I'll just give you a very gross example. Uh, if the child is having difficulty in playing, right? Let's say he has to sit on the chair and then do a puzzle activity. Now, in order to do that particular action, there are certain prerequisites that is involved. Excuse me. The child's cognitive functions, the child's sensory functions, the child's motor functions, and how the child is emotionally and socially accepting to that environment. So these are the prerequisite skills that is involved. So when we look into these areas, from the gross area, we will just see the child is not able to sit in a place and perform an activity. But when we look in depth using this evaluation, we will be finding a lot of other simple factors, small detailed factors where we are lacking in. So if the child is not having an attention span, for example, the sitting endurance is affected. So definitely we have to work on the attention and sitting endurance combinedly, so that the work that has been exhibited from the child onto a task is more productive and efficient. So that is the importance of the evaluation. And then the interventions will definitely be programmed on the basis of the concerns from the parents and limitations observed from the child, and documented along the course of the therapy. Okay, so only after we take this evaluation we'll be able to document, and from the data that we have collected we'll be programming interventions. And reassessment. So why reassessment is very important? So reassessment is like to check the performance level of the child and plan for any further interventions. Now, after taking an initial evaluation, we would let's say take two or three goals into the picture. Maybe eye contact, attention span, name call response. So these three are the very basic factors that we need to get achieved in the earlier stages to in order to perform certain other functions more independently and efficiently. Now after we now there'll be like 3 months, like 2 to 3 months. Now we work on that particular areas for a couple or 3 months, and then later we'll have a reassessment going back. Reassessment is something that again we would check back, like where the child lags in and how much has improved till date, concerning with all those areas, with all those limitations, with everything that the child has been lacking in right now, how much independent and productive that the child is able to perform right now. So based on that interventions, we will be able to plan accordingly whether we need a graded task, or we need to change the intervention plan, or is it something that the child needs a different interventions, maybe a psychological or a neurological support. Right. And then the slogan here. So I just wanted to introduce the slogan to you. What matters to you and not what is the matter with you. Now, this slogan is very much practiced in by occupation therapists. This is the approach of an occupation therapist towards the child. Now, what exactly this slogan means? Now, when you try to take a child out to a public place, to a shopping mall, or to any kind of a normal grocery stores or malls and anything, example, uh, all of a sudden you find that the child is showing a lot of tantrums. So the child not only throws tantrums, but also wants something, but the way of communicating is not very acceptable, right? So they start falling down on the floor, and then kicking the feet off, and then shouting, screaming, and then sometimes get involved into an aggressive behaviors, destructive behaviors by throwing items. So these kinds of things happen in public place. Literally what the parent or the caregiver would experience at that point of time, If it's at home, it's a different issue. But when it comes to the public place, the perception or the understanding will be totally different. I mean, we would not act very wisely there. It's not for the child that we will be acting, it's for the society that we would be acting. Either we would drag the child away from that place, or we try to reinforce them by asking what they want, or even beat them also as well. So give them 2 3 taps and then ask them to stay quiet. So this is a very typical behavior from the giver or the parents that we do it in that particular environment. At that point of time, what is the exact approach that you use? There are only two ways that your brain would think. What exactly is this child's problem, or what is my child require right now? Those are the two ways how the brain would act in that manner. If your brain thinks what exactly is the problem with this child, definitely your approach and your action should be different. Like as I told you before, you know, like removing the child away or giving a beating to stop the tantrums, because we are more worried with the society judgment, right? And then what matters to you is something that no, the child, sorry, your brain will start thinking another way. Like what exactly is my child needs, or what exactly my child want, what exactly is making my child show throw tantrums here. Is it something that he wants a toy, or he doesn't like the place, or is he overwhelmed with the crowd, or is he feeling insecure? So when you try to think in that manner, definitely your approach and the way how you deal with that tantrum in that environment would differ. So when we try to approach the kid, when occupation therapy therapists try to approach the child, we would definitely use this level of training, or this level of thought. It's not only occupation therapist, any therapist, or regardless with speech therapist or an EB analysis, would definitely start thinking in this manner. So what exactly is the matter with the child? What he wants, what does he need? Is it because of some behavior that he is doing it, or is it acceptable? Is it logical for him to throw tantrums like that, or maybe he's really wanting something that I should really give him out? All right, so this is the slogan, and this is how the approach basically that will be dealt with. And then let's start with a lot of prerequisite skills now. As I told you, I won't go in detail because the main part is yet to come, right? So I'll just give you a small touch or an insight on what the prerequisite skills all about and how we occupational therapists deal with it. So these skills which I'm going to explain to you is like a very stuck to what strictly to an occupation therapist manners. So that should not be an understanding, but these skills can be focused on by different professionals also as well. But majorly we would try to implement these areas in a different formats. Now for example, why I'm telling this, I don't want to have give you any confusions on the way how we approach. Now you find another professional using, for example, this motor skill, and then we perform this motor skill. It should not be understood in a different way. Okay, so although the skills is the same, although we overlap in certain goals, the approach and the response what we get is different. Maybe we work on the same skill in a different aspect, but another professional will work on the same skill on a different aspect. It's like, it's very complex to explain, but I wanted to know it's a network. The skill is not exactly just one skill alone, it's a combination and a network of different skills involved. Right. So, what exactly is motor skills? So, these are the actions that involve the movement of the muscles in the body. Right. So, the motor skills is like the any action that you do, either with your hands or legs or with your shoulders or any kind of movements that you do. Everything is a motor skill. So, these are subdivided into two types: gross motor skills and fine motor skills. Raw skills are something that you use a larger limbs, larger movement of the arms, legs, feet, or the entire body. Like for example, you crawl, you run, you jump. So these are all gross motor skills where you use your hands, legs, feet, and your entire body to do it. Fine motor skills are something which are described as a very smaller actions that you use your fingers to do it, your thumb and fingers, or sometimes your tongue to taste objects. Now, giving an example, for example, now if we want to take an object from down from the floor and then throw it, so picking up the object from the floor down, when you're picking an object like a ball, right, where your fingers are in action to pick up the ball and you use it. So that is a fine motor skill. And then when you lift it up and throw to a higher distance, to a very longer distance, so that is the gross skill where the shoulder implementation comes in. Now these skills doesn't act individually. Now gross and fine skill do not act anywhere individually. It acts together. Whenever you try to do any kind of task, now for example, look into the pictures here which I had given. The right corner up and the right corner down. When you look into those pictures, you will find both the skills that is involved. When you see the down picture, when the girl is actually climbing up the rope ladder, she is using her gross skills such as the shoulders and hip muscles and even the feet to support herself in climbing up, and she's using a fine motor skills, that is the fingers, in order to hold that particular rod. Okay, so if the fine motor skills is not good, definitely she will not be able to climb up, or if the gross motor skills is not good, definitely the stability would be hampered and the entire activity what she's trying to do here will be incomplete. And that smile there is achieved is from the emotional content. Yes, I'm able to climb up, I'm able to perform my action more independently. So that is the emotional content that the child receives. If they are not able to do this particular action, you'll not be able to see that smile on the child's face. Okay. And then the cognitive skills. So in cognitive skills, what are the areas that we look into it? So the attention, concentration, comprehension, executing instructions, problem solving skills, shape concepts, size and color concepts, object use, identification, sorting. Now these points are not exactly very confined to only these points, but still, like when I have to explain about what exactly is cognitive skills and why the child needs cognitive skills in order to do an activity, here it is. Now when the child, as I told you, when you have to give a puzzle activity, you're making the child to sit, and you're giving him or her some kind of activities, like maybe a puzzle activity, or it can be a bead activity, or even it can be water play, or any kind of rajma ragi play, any kind of play it is. The child must have a proper attention to do that particular tasks. The child must have good level of concentration, and then a comprehension or an understanding level to instructions. For example, if you say to your child, please sit and then complete this activity, or please take that crayon, for example, he must be able to understand what you're exactly saying and execute accordingly to what it's been commanded to do. Problem solving skills. For example, if the when painting or coloring, if the child accidentally drops the water on the paper, what he or she can do. It's not to a higher level that we expect the child to do a problem solving skill. At least they must be okay to change the table or clear the table off, clean it up, and have a painting or drawing done in on the other paper. So what happens? Like instead, when they don't have this problem solving skill, they'll eventually sit in the same place and then start crying, not knowing what to do next. And then definitely shape, size, and color concepts, which is very necessary. And then when you wanted the child to say, when you instruct the child, please take the red pencil, or please take the red pen, or take the green color crayon. So when you give these kinds of colors identification, right, the child must be able to identify what kind of colors and what colors is the instruction being given, and pick up accordingly. Objectives is something that, okay, when I have to give a ball, the child must have that cognitive function to know what has to be done with the ball. And if you give a rattle, the child must be able to know what I should be doing with the rattle. They must not exchange. They must not throw the rattle and jiggle the ball, right? That will be a different object use. So if there's a ball given to me, I have to throw the ball or play with the ball by rolling it down. Or if there's a rattle given to me, I can jiggle it up for the sounds. So object uses. Identifications. Identification is something that where the child is able to identify certain objects, what they require for the certain activities to be done. Sorting, yes, they must be able to sort out. Now, what goes with fruits, what goes with vegetables, what are the colors, so these kinds of things. That is when you try to instruct the child, like please take the fruit basket and come, or please take a pineapple from the fruit basket. So they must be able to understand pineapple falls in the fruit section. So this is where I have to go and pick up the particular object. And then visual perception skills. So visual perception skills is something very complex to understand. So when we look into the term alone, you might understand that is it very important for the child to know this big skill. But yes, it is very important. Now the terms here, like within the boundary, depth perception, topographical orientation, and form ground perception, and of course scanning. So these kind of skills, are like very compacted. Like I'll just explain you. Within the boundary is something that should be done within the circle. Now you draw a circle and ask the child to color within the boundary. Very basic, typical function would be just scribbling it out. The color would go outside the circles also as well. But to get it more productive, we should be able to draw within the circle, right? So the speed regulation and able to analyze where I have to stick myself to what I have to do. Have to be doing is within the boundary. Depth perception is like how much I have to you know implement my limb movements in order for the particular depth to achieve. For example, the child is able to walk up and down the steps, but the child has to climb up the steps. For example, when you're calling from the top floor and you're asking your child, please come up. So eventually, when the child has to walk up and down the steps, they have to have this perfect or a correct depth perception. Only then they'll be able to analyze their steps and place their limbs accordingly on the steps to go up or climb down. If there is a disturbance in their particular depth perception, mistake. Topographical orientation, of course, the child must be able to understand where and how the distance matters, from one room to another room, how to go and how to come. Some kids will be very good in these kinds of skills. For example, even if you hide certain toys in a particular place, they will know how to find it out. So how? It's because of the topographical orientation. Foreground perception, ability to differentiate between the foreground and the background. And scanning, of course, when you keep a toy among in a different mixed place, a toy among a certain another on non-reinforcing items, or probably let's say you keep the child's toy in a bedroom or the child's toy in the hall itself, the child must be able to scan everything. So what exactly is the toy and where the toy is? Probably the child would see a lot of other things, maybe a chair, maybe a television, or the kitchen room, or the sofa, like different things around. But ability to scan among all those things, filter it out and find out the correct object that the child needs is scanning. And social emotional skills, definitely the eye contact, name call response, understanding the facial gestures, recognition, peer interaction, expressing needs, turn taking, sharing, and greeting. And self care are the dressing, eating, ambulating, toileting, hygiene. Now, these are the basic ADL functions which I had told you. In the beginning of the presentation, I told you about the basic ADL functions, right? So this is where the occupational therapist really working to get an independent level. Now, you might ask me why the child necessarily at this particular age must be knowing how to do these things independent. Well, definitely, we parents are there to help them out in order to dress, in feeding them, in assisting them in toileting, or even maintaining their personal hygiene also as well. But certain independent level, for example, definitely we have a developmental milestone to achieve. Like a child not be able to do these kind of things as independently right from the beginning. There are certain age factors where they have to achieve in order to get certain things done independently. Now you ask the child, okay, we are getting ready to go outside. Let's go for shopping. Don't on your shoes. Like wear your shoes on. So the child must be able to at least wear the shoes, not at least tying the lace, but still putting the legs in or the feet inside the shoes, right? And if the child has to like at least remove the dress off after the school or after they finish their play activity, they must be able to be independent in at least doffing it off, like removing the dress off. And ambulating is walking. So whether they're able to walk from one end to another end or one place to another place, that is where I told the topographical orientation. So everything is like mixed, interlinked. So these kind of small things the child must be able to do it independently. uh, Dependency, yes, we could avail a lot of dependency for the child, but only to a certain age. But after a certain age, when the child is able to comb on its own, when the child is able to remove the dress on its own or wear the shoes on its own, we must encourage that independency level. And then now, very important topic in this child psychiatry populations that I'll be discussing to you is the sensory integration. Now, the areas that I've been focusing on, right? So the social emotional skills, the visual perception skills, cognitive skills, motor skills. So these all skills are like a prerequisites areas. Now I told you, like when the child has to given a simple activity or a task to perform itself, we must have these requisite skills achieved also as well. If the attention is not good, definitely there will be a lag in the activity performance. If the eye contact or the instruction following, or even if the depth perception or even scanning is hampered, we will not be able to get any particular task productive. Now, apart from all these prerequisite factors, what is a very important prerequisites factor that we have, which we typically call the sensory integration. So, what exactly is a sensory integration? Now, I'll give you an example. For example, now you are working, you're cooking something in the kitchen, for example, right? You're cooking something in the kitchen, and then accidentally you touch a hot vessel. So, what exactly you do? Immediately, you will withdraw your hand. Yes, that is a typical response. You will remove your hand either with a motor response, or and also along with it, you will say an ouch or something like this. So definitely there is some response to it, right? So whatever happened, there is a action, there was a response. Now when you had touched the hot vessel, right, so that is the stimulus. Now the temperature, the heat temperature is being traveled through your nerves to your brain. That is the stimulus. And then after sending the impulses to the brain from the stimulus, it processes it, generates, and then sends the same impulses back to the particular limb as a response. Brain is saying, yes, I agree that this is a very hot substance and you will not be able to handle it, so I am commanding you to remove your hand away. And then that response will be flowed back again through the nerves to the targeted area, that is the limb where it touched the hot vessel, and immediately the response would be you withdraw your hand. So that is the sensory integration. So it refers to the way the nervous system receiving the message from the senses and turns them to an appropriate motor and behavioral response. Now the response, like what is being done, right, it's been done in two different forms: motor and behavioral response. Motor response is something that you withdraw your hand away from the hot vessel. Behavioral response can be the response towards the pain. Maybe you would say ouch, or maybe you would say oh my god, and then you rub your arm. Or it can be even an aggressive behavior also, like shouting, who kept the hot vessel right next to me? Or no, getting angry on yourself, why shouldn't I be more precautious? So these are kind of responses. So motor and behavioral response. And these responses, the pathway is there, right? So the message going to the brain and then coming back for the response, this pathway will take just in a mini fraction of a second. It will not take time where you have to go to where the message goes to the brain, process it, wait for the time, and then comes back for the response. So it happens everything in a mini fraction of a second. Now that is sensory integration. Now, what are the senses? Now, we have different senses that we collect information from, right? Now, in back in school, we would have studied a lot of senses, basically five: vision, hearing, smell, taste, touch. Vision is something to do with seeing, hearing, something to do with hearing. We call it as olfactory and auditory. Smell, we have something to do with smell, taste, and then touch. Touch, we say it as tactile. And then apart from all these five senses, apart from vision, hearing, smell, taste, and touch, we have very important two other more senses: proprioception and vestibular. We have another sense called interoception, which is not mentioned here because interoception is not very targeted sense. It's not very problematic sense. It's very rare that we have that sense problematic. Interoception means feeling of internal organs, like I'm feeling hungry, or I'm feeling thirsty, or I want to use the washroom, or how do I feel about this movie. So all this kinds of internal, the fear and all these internal organs feeling, there's something to do with interoception. Now, what is exactly this proprioception vestibular? Proprioception means joint position sensation. Okay, so joint position sensation means when you're sitting on the chair, or when you're trying to throw a ball, you're not aware all the time that where your body or limb movements are placed in space. Now, our feet is contacted to the ground, but our body upwards where the joints are placed in space: shoulder joint, hip joint, elbow, wrist, and all the interphalangeal joints. So these joints are placed in space. We are not aware all the time where is my joint is placed in. In case if there's a person who's pushing us from behind, or there is a slip that we are trying to trip and fall down, so at that point of time we would try to analyze where is a joint moving, whether we're going to fall, and then we address that particular situation, manage our own limb movements, and then coordinate accordingly to prevent from fall. If it is too large, we might fall, or if not, we might try to embrace that fall, right? Yeah. So we'll try to prevent from injury. Now, so the definition says like this: it's an ability to where the child is able to understand where the joints movements are in space, or the joint position is in space. If I have to lift my arm like this, I need to know where my joint position is correctly. The best example would be where you say hi, right? Whether I have to, sorry, not high. The best example would be climbing up the stairs. So when the child is climbing up and down the stairs, ability to understand how much I have to move my limb to keep my leg on the next step, that is proprioception, joint positioning sensation. Where you position your joint in space. Vestibular means joint movement sensation, right? So where you want to move, how much you want to move, how much intensity or pressure that you need to apply in this movement. Example would be waving high. Now, waving high or by to a very closer person would be something like this, very, very low. But if you want to say bye to a very far up person, you would wave your arm even more higher. The intensity would go really high, right? You'll wave very largely. So, and this proprioception and vestibular, it goes combinedly together. So, proprioception joint position sensation, vestibular joint movement sensation. Now, this proprioception and vestibular go accordingly together, meaning whenever you do any kind of action or any kind of work, the output would be more from this particular senses. Now, when you're trying to walk itself, when you're trying to cross the road, for example, you're crossing the road and all of a sudden you find that a vehicle is very close by. Definitely, what you would do is either you stop or you speed up you accelerate yourself to cross the road. So what happens there? Your joint positioning, your brain understands the signal, and then it says to you, see, your joint is somewhere over here. So I need you to move the joint even more in a higher pace. Keep your joint in that position so that you will avoid your accident. Or move your body in this particular manner, in this particular speeds, in order to avoid from getting hit by a car or any other vehicle. So you're regulating your joint position and your joint movement in space. So that is proprioception vestibular acting together. Now, what exactly is sensory integration disorder? We call it as SPD, that is sensory processing disorder. So it's nothing. It's only when the signals that goes to the brain and then comes back as an output and responding to a particular stimulus is not being done correctly, or when there is a trouble in receiving and responding to that particular information, that is when there is a sense integration disorder or dysfunction happens. Now, let's take that same example itself. When the person has touched the hot vessel with his arm, typical action would be, as I told you, withdrawal of the hand. You remove yourself from that place, or from that hot vessel. But instead of doing that, the patient, or sorry, that's the person has kept that hand in the hot vessel for a longer period of time, not knowing that it's even being hot, and he has to withdraw his hand off. Or he might over exaggerate it for small things. Oh my god, this is too much, and I'm not able to handle the pain, or I'm not able to handle the temperature, there's burns and everything. So these kinds of things, when they try to respond in a very exaggerated level, or they respond to a very low level, that is where the sense integration happens. We call it as SPD then. So a typical response is what we need, right? And then, so what exactly is this SPD talking about? There are three divisions. One is a sensory discrimination disorder, and we have sensory based motor disorder, and then we have sensory modulation disorder. Now, what exactly is a sensory discrimination based motor and modulation disorder all about? Now, I told you about the response being delayed, right? So that falls in any of these three categories, or all the three categories together itself. Now, let's take the child itself for an example. When you come to a sensory discrimination disorder, it's more of understanding what kind of sense is accurately being done to the child. If the child is seeing or hearing to something, or feeling anything, or tasting anything, or no, or smelling anything, so that individual or that particular child must be able to discriminate what kind of senses is what, like what the sensory stimulus characteristic all about. For example, the child, when looking into an alphabet, as I mentioned here, do I see a P or do I see a Q? Do I hear a cat or do I hear a cap? I might have told cat. but what exactly it is, like, is it cat or cap? No, the discrimination from the sensory point of view is the auditory impulses, like how much I'm hearing, whether I'm able to discriminate, how far I'm able to discriminate. When I look into certain object, is it this or is it that? There's always a cognitive dissonance happening here. You're not able to discriminate each particular senses. And then basically, the individuals with very poor sensory discrimination will appear awkward in both gross and fine motor skills. Exactly, like, when you're not able to discriminate what kind of senses exactly is this, what kind of information or the input that is coming to me, what kind of response should I be giving when there's a difference or when there's a clash in that thinking, definitely my action or the response physically towards it also will be very awkward, or something to say very unproductive. Now these individuals or these type of children would take a longer time to process an aspect of sensory stimulus. That is when the lag happens. When you try to say hi to a child. Now the child would start thinking, yes, what exactly is happening? Is he saying hi to me? What should I be doing now? Should I respond saying back to them, saying hi? What should I be doing? You know, that is how the lag will happen. Like, they'll take an extra time to exactly process what should be doing, what I should be doing it. And then what is sensory based motor disorder? Now, motor disorder, it's only from the sensory aspect that I'm talking to you about. What from the aspect of sensory is happening? Now, we have something called postural disorder, and we have something called motor planning problems. That is dyspraxia. Now, postural disorder is something that where the child is not having enough stability to perform his or her own body movements. For example, the child is playing cricket, or the child is playing running and catching, for example. Now, while doing this running and catching play, the child must ambulate or move from one place to another. So definitely there will be this physical stimulations, definitely there will be this limb movements acting very adequately, right? It must be only then they'll be able to control their body movements appropriately enough from one place to another place. Now, when they're moving, it's also balance that is coming into it. Now, when they're not able to have a proper postural control, definitely balance is also affected. So, what exactly happened? They're not able to even have a good standing or sitting posture. So, if the posture is affected, the movement or the execution of the task physically also is getting disturbed or getting hampered. And eventually, the demand from the environment is getting lost, which means the productivity of the play in that time is getting weakened. And what exactly is dyspraxia? So, motor planning problems, also called dyspraxia, is something that the sensory information is having trouble processing it. That in turn will result in problems like planning and carrying out new motor actions. Now, for example, you ask the child for a high five. How many times that you find the child? Have you observed like child is not giving a proper high five? Or when you ask hi itself or wave bye, the typical action will be bye like this, a normal how we say bye. But in turn, the child would flip the hand backwards where the palm is facing front of their face, and then they would say bye. So it can be a dyspraxia, or it can be because of that they are not learnt the skill yet. So it differs. But in order to find out what exactly is the problem, that is where the assessment has been done. So, and then that is all about the sensory based motor disorder. Now we come to sensory modulation disorder. So modulation, as a word, it's all about the tuning part. How you can tune the volume up high or tune the volume up very low, or something that you keep on doing it high and low and high and low and high and low. Now, what is exactly this over responsivity? Like, we have modulations divided into three phases: over responsivity, under responsivity, and sensory seeking or craving behaviors. Now, over responsivity is something that the child is overly sensitive of something. For example, a small snap like this would make them feel that it's something like a thunder sound. No, or maybe you would say very softly hi, but still they will feel, that auditory impulse that is going to their brain is something really high frequency, and they will not be able. They'll shut their ears off. They'll only try to avoid a lot of sensations. So an aversive behavior will be seen in these kinds of responsibility very typically in feeding problems. Like, how many of you have trouble in feeding your children? This is the same. Like, from the sensory aspect, it can be behavior also, but from the sensory aspect, when you try to implement or introduce any kind of food particles inside the child's mouth, because of this over responsivity, the taste, or the sensation that is coming out inside from inside the mouth will be very, very impulsive, very, very tingling. So definitely the child, what they will do is they'll try to be aversive. How they will be aversive? By either spitting the food out or just showing tantrums in not to eat. That is over responsibility. And under responsibility is something that the individual is not even being motivated to do anything. All the time, whatever task you do, whatever fun activities that you show, or if you take the child to a very high level, the malls, or make the visual input more overwhelming, but still the child would not have any kind of reaction to show. It will be very, very, very submissive. And then seeking or craving behavior, something that the child always seeks for something, always wants something. Like, for example, um, uh, how many of you would prefer touching a particular object all the time? Now, for example, now I like into touching a soft textures. Now, when I have to touch a pillow or a fur kind of pillow, I'll might touch it all the time. I like the texture. I crave for it. No, that makes me more soothing, more comfortable. Like, I feel like doing it all the time. So I'm seeking for it. But but that's okay. That's normal. When I have to stop, I need to stop. But when I don't know when to stop, and I feel that is the basic functioning for me to do it in my everyday activities, that is when the problem comes. A very typical example would be where we constantly you find a child moving, crashing, bumping or jumping every time, or sometimes even with food also. When it comes to oral seeking or craving, they'll prefer only hard substances, only eating apple, or only prefer eating crunchy items, or they would prefer only very soft liquids, soft items, like pure foods like banana, porridge, these kinds of things. So the craving part, it's more of, because of craving, they get into more of selective patterns also. Like, this is how I need to do my action, this is how I need my activities to do it. Like, most of the child would like to play rough, or most of the child would like to play smooth. It's all because of that particular senses that is being processed accordingly. Okay, and then so what are the actual symptoms that includes? Now, before getting into the symptoms, I wanted to tell you these sensory processing disorder is not confined to only one sense. It can be from any kind of sense. It can be through visual, it can be through hearing, it can be through proprioception vestibular, or it can be even through smell, or even tactile, that is touch. So I'll tell you how it is. Now, for example, if the child is having, let's take one sense for example. For now, let's take proprioception vestibular. Okay, the joint position and joint movement sensation. Now, according to the sensory modulation, if the child is having over responsivity, then definitely the child would start showing a lot of hyperactive behavior, running all the time, jumping all the time. Understand, it's only on the terms of proprioception and vestibular impulse, sensory, which means the joint position and joint movement sensation. So the joint position will be high, joint movement sensation will be very high. That is where you see a lot of rocking, jumping, not able to sit in one place, then hanging, yeah, not knowing what is dangerous and what is not. They'll climb on top of the window panes or on top of the table. So these kinds of things will happen in over responsive things. Under responsive is something where they are not like to do any kind of physical task, very, very demotivated. We would misinterpret, okay, we're saying that the child is sick or not interested to do anything, but from the sensory point of view, maybe the child is not having that particular sense that is popping out from them. Seeking is something that all the time they would start clapping, or probably they would start getting into a more of stimming behavior. I'll explain to you what is stimming. Okay, so these modulations will happen. Now, these modulations, as I told you, not confined to only one sense, but with many senses. Which one example I gave you? It's from the proprioception vestibular sense. Now, what are the symptoms that would include? Now, from if you find if the child is having a SPD, a sensory processing disorder, there are a few symptoms that can include. One, no eye contact. Initiation and maintenance. That means when the child is looking at you and maintaining that eye contact to you is different. Okay, so when the child is looking at you and sustaining or maintenance means when you're singing a rhyme to the child, Johnny Johnny yes papa twinkle twinkle little star. So when you try to sing this particular rhyme, the child must be able to maintain that eye contact to you. So if the child is not able to maintain or even initiate an eye contact, is one symptom. Doesn't respond to name call or follow instructions, sensitive to loud sounds. For example, when you switch on the mixie in the kitchen at home, the child is very sensitive that it closes the ears or goes hide somewhere or shows tantrums or aggressive behaviors, these kinds of things. Unable to mingle age appropriately and prefers to be alone. That is very solitary play. Not the child will not be willing to mingle himself with any other peer members. Lack of social smile. If anybody else or relatives come home, they will not even bother to even give a smile. And trouble in sitting one place, very very typical. So the child is not ready to sit in one place all the time, wants to just move around from one place to another, does not feel pain or fear, not interested to touch an object, prefers to be in motion all the time. That is, it can be a rocking behavior or it can be walking all the time or running all the time. Doesn't take interest to it. A very 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 common problem that is presently readily present in present scenarios. Now the child will not have any interest to eat. More I could say the child's processing towards eating will not be very productive. Then stereotypical behaviors like stimming. I'll explain stimming down the line. So these are the symptoms. Now, what is exactly sensory integration training? Training is something that we will enable the children to have a very sensory diet protocol. A sensory diet protocol is something that what kind of sensory activities that they have to do, and what kind of dosage and what frequent level. Because whatever activities that you try to do, everything is sensory based actually. Now, strictly speaking, like even we adults, when we try to do any kind of physical task, there is a sensory implementation that's happening. When I have to even write something on the paper, or if I have to look into the mirror and comb myself, so groom myself. So these things, everything has a sensory impact. But there are few specific sensory activities that are directed only to that particular sense, where in turn will help the child enhance their physical and mental stimulation through sensory in a very structured and very repetitive manner. So that is sensory integration training. We would provide a lot of activities in a sensory based format. That means we would use water, we would use vision like lights, we will use even music for sounds, or we use a different balance training activities. Whatever the sense that has been available, all the eight senses will be targeted. Now, what are the sensory integration activities? I will not have time to explain to you all the activities. When you enroll yourself into an occupational therapy treatment, then I'll be detailing giving you an idea of what activities for what. But basically, this is how it has been divided from tactile activities, vestibular, proprioceptive activities, oral strengthening, visual stimulation, auditory, gustatory, olfactory activities. So each sense has their own activities. Not everything is combined. Each one will have its own. Now, kids who feel too much or too less and sensory overload. Now we come. Now, kids who feel too much is the oversensitiveness, which I had explained earlier. Or kids who feel too low is something to be, tell about the under responsibility, which I told you about. No, as you see in the picture, the child is not even interested to do any of the activity, and whereas you see other child showing tantrums in public place like this, the left top corner, and then the right corner is the sensory overload. So basically, it's just like that. It looks very simple. Now, when you look into the two pictures above, on your left top and your right top, when you look into the pictures, it exactly seems simple. When you exactly when you, if I ask you what the child is doing in that picture, you will say the child is eventually crying. The only difference is here with the public place with mom, or here the child is only alone, crying, or maybe he or she wants something. Now, I would actually differentiate. Now, when we look into it, will be able to differentiate what exactly is over responsibility. This one, what exactly is over responsibility, and what exactly is sensory overload. Now, what is how different is sensory overload from over responsibility? Now, if I have to touch certain things, my senses are very, very, very sensitive. Now, because of sensitiveness, we might try to be over responsive to it. Either we might do our motor and behavioral response in a very high action, that is over responsiveness. Sensory overload is something that now when I'm sitting in one room in within the four walls, I might have all my senses well balanced. Maybe I will listen to things very mildly, or when I have to look into the things very in a very limited circle, or I can feel things very lightly. But if I have to shift myself from one to another room, or if I have to shift myself from my home to an outside public place, that is where my senses become a little more enhanced, where I'm able to look into a lot of things. I'm able to feel a lot of things, the rushing of the wind or the heat, or even I'll be able to hear a lot of things, the traffic sounds and visuals, everything. So the amplification is modified, like it's getting the senses are getting modified from low intensity to high intensity. So when all these senses, from hearing, from sight, from your joint positioning sensation, everything is like together, acting together, the child will not be able to process accordingly in a very correct manner. So that is when sensory overload happens. Oh my god, what is this, why I'm telling? So it's almost literally, giving an example, it could be like where you're sitting in a crowd and when everyone are speaking together at the same time. So what happens, you'll feel very frustrated, right? You'll feel like, what is this, ask someone to stop, I'm getting a headache. So this is what it is, how the child typically feels. So what happens when sensory overload comes? Definitely, if it's an adult, they would come up with either verbal instruction asking them to stop, or they would move from that particular place away. But in terms of children, there's only one action that will happen, that is the stimming. So now we'll explain to you what is stimming actually. So stimming is something to do with a self-stimulatory repetitive behavior, right? So still self-stimulatory repetitive behavior in the sense, for example, now we all have stimming. For example, you might have seen a lot of, even we adults try to do a lot of repetitive actions. When we write something on the paper with the pen, we try to meddle with the pen all the time, or we tap the pen on the table continuously, or ladies would try to play with their hair, and twirl their hair like this, or shaking of the legs sometimes during an interview times, when you look into the candidates, they'll be shaking their legs out of anxiety. So why these kinds of action that we usually take place? So they're universal to everybody. It does happen. Now when it comes to this particular actions, it happens in different emotional criterias. If I'm sad, if I'm happy, or if I'm anxious, or even when I'm depressed, I'll have a certain particular repetitive actions. Now, for example, if I am a little overwhelmed with certain things, or if I'm a little depressed or anxious, what I try to do is I listen to music. So wearing a earphone on and listening to music in any environment is acceptable. Like people who are looking into the stimming part, what I'm doing is something that is that they won't feel very absurd in. No, they will know, okay, fine, acceptable, he's listening to music, it's fine. Whether I have to listen to music at home or whether I have to listen to music in while traveling the bus makes sense. But if I have to try doing hand flapping, for example, or if I have to shout if I have to do that particular vocal stimming, or if I have to look into a certain object all the time, very constant, there'll be a different action that will be executed. Not every child will have the same action. Each child will own their own style of presenting their stimming patterns. Now, very importantly, I want to tell you is, well, the stimming part is not something to do with whether it is socially acceptable or not. Now, when you take a child to a public place and you find your child doing a repetitive self-stimulatory behavior, what we try to approach is like, oh, there are a lot of people who are watching. It's something really awkward, very inappropriate. So let's not have my child do this particular actions. Let's say hand flapping itself. So they will try to hold or block the child from doing hand flapping, meaning that they really want the society to accept what the child is doing an action for. But although it is one way accepted, what we regard stimming as is something that when it hampers the child's productivity level in their tasks. For example, if the child, if you're giving an activity for a child, let's say stacking rings or a puzzle fixing activity, when the child is given that activity, he or she must be able to complete that activity without having any disturbance. In order to complete that activity, in between when you're performing, when the child is performing, if they start doing hand flapping, that is hampering their completion and the productivity of the task. That is where we call it and regard stimming as being a little problematic, and we need to address. But other than that, if you ask me, is stimming is harmful or not, I would say it's not harmful, because that is only a self-stimulatory behavior. Self-stimulatory behavior in the sense, when I'm really overloaded with something, I stimulate myself to be more calm and relaxed, so that I can relate to the environment more gently as possible. So as long as this stimming pattern is harmful to other person, or it's getting aggressive, we don't have any worries to we don't have anything to be worried about. So that is stimming. Now it's very typical in children. Now you look into the stimming here. When you see a small picture here, the child is actually having a little trouble, right? When he or she looks into the laptop, when the rhymes or any television program is being shown, the child eventually, out of happiness, they try to flap their hands. So that is sort of an excitement. He or she is trying to self-stimulate himself. Yes, I'm happy. I'm doing it. This pattern is very normal for this child. But when you try to have in your manner, when you put in his shoes, maybe you will try to clap. You will clap very continuously out of excitement, or you might even shout out of an excitement, out of an ecstasy. So even that is stimming. So what is exactly problematic here? That is the question that we need to come across. Now this is totally fine. It will really subside on its own. It's only thing that we need to, if you want to address, we need to get it more into a destructible manner, or turn that into a more productive, but not any time stop the stimming part. Okay. But if that stimming right now, as you see, that child is hand flapping or shouting, if that is coming in between the task what is demanded to do, that is when we need to address it. Now, these are the few points that we need to look into it. One is short form, as I told you, that includes hand flapping, rocking, spinning. Now, hand flapping, rocking, spinning, or these kinds of very repetitive patterns, it should not be misunderstood that if the child does any rocking or spinning behavior, that the child has stimming. No, it should be very repetitive. We call other times, or otherwise called as stereotypical behaviors, right? So stimming is just a short form for self-stimulatory behavior, and it should be repetitive. Only then it's called as stimming. And it can be from any of the senses. It can be any form also, as I told you. If it's from the visual stimming, as from the hearing, auditory stimming. Like what I can see from the child here in this picture is the visual stimming. That is, when he looks into the visual, only then he will have an overload, a response of happiness that he exhibits in that particular action as hand flapping. And it can occur in any intense emotions. If the child is overly joyed, or overly depressed, or overly anxious, or want to escape, those kinds of intense emotion types, and should not be blocked but only distracted or turned to productive. Because what will happen if you block is, like when you try to hold the particular stimming, if I'm hand flapping like this, and if you hold the child's hand, not saying no, don't, no, don't do it, or if you hit the child's hand if they are doing hand flapping, the result would be more intense. The child would find another way of stimming, and it could be, trust me, it could be uh, more bad than the other stimming that he has already done. Probably the severity would increase, I would say. So anytime, please don't block it. And then it should not be harmful. Definitely, stimming is not harmful. It's a self-stimulatory behavior. Definitely, it's upset on its own. Yes, but if it only when it when it relates to self-injury behavior, or like a headbanging behavior, I would mean, or throwing objects, destructive things, only then we need to block it. We need to address it's a little harmful. So not all stimming is due to sensory. Very, very, very important information that I wanted to tell you. Not all the stimming can be due to sensory. It can be behavior also. For example, if the child is doing a particular action very repetitively, it can be sensory, but sometimes the child can project in form of behavior also. Maybe the child wants to escape from that particular demand. Then he might be doing that kind of repetitive action in order to escape. Yes. And does it hamper the child's task performance and its productivity? So this is the question that you need to ask yourself. Whenever you find a child doing these kind of repetitive patterns, does it hamper the child's task performance and its productivity? Like if you're giving a child some work to do it, the child must be able to complete that task on time. If the child is not able to complete it, definitely there is a problem because of the stigma. Yes. So, and that is all about the occupation therapy, the very pertaining to the child psychiatry unit. And so, emphasis on what the child can do instead of what he cannot do is my conclusion phrase. That means to say that always support what the child is able to do it, and no, we'll focus more on what things can do. If the child is able to throw the ball, doesn't mean that the child should, your child also should be able to throw the ball that effective. If the child is able to at least roll the ball over, it's well and good. So we'll emphasize on that particular skill, strengthen it out to get more productive so that the child will eventually learn how to pick up the ball and throw. Okay. And every child is unique. So hope you have understood, so what is exactly an occupation therapy all about. And thank you. Thank you so much.